Hi, everyone. Welcome to the Health Terminology Standards seminar series. My name is Linda Bird, and I'm an adjunct assistant professor here at the University of Victoria. I'm also an active implementer of healthcare interoperability standards and the instructor of UVic's HIMP 597 course, which is hosting this HTIS seminar series. For those of you who aren't students, HIMP 597 is the field project in health informatics. So welcome, everyone. Before we get started, let's begin the territory acknowledgements. We would like to acknowledge and respect the Lekwungen peoples on whose traditional territory the university stands, and the Songhees, Esquimalt, and Wasanich peoples whose historical relationships with the land continue to this day. So this is the second seminar in our Health Terminology Standards seminar series, and the topic for today is SNOMED CT trends and latest developments. But before we get to that, let's take a quick look at the next few weeks. Next week, we have Debbie Pinter, who'll be presenting Building a Better Health Record at Alberta Health Services. And then on July 2nd and 9th, Derek Ritz will be joining us to explore computable care guidelines and the buildable digital health blueprint toolkit. So there's lots of great topics to come. And also please note that all of these sessions will be recorded and shared on the school's website. If this seminar series interests you and you would like to turn that interest into a qualification, you can enroll in the Certificate in Health Terminology and Interoperability Standards. This is a one-year part-time program with 4 graduate level courses, including this one, which are done through weekly online evening classes. Plus, there's a virtual workshop in the course that we've just finished. This is the only terminology standards program in Canada that's accredited with CHIMA, the Canadian College of Health Information Management, to become a certified terminology standards specialist in Canada. So if you'd like to join our September 2024 intake, the deadline for applications is now July 15th. To find out more, you can quickly scan the QR code or visit the school's website at this address. And so today I am delighted to introduce a good friend of mine, Alejandro Lopez Osornio from SNOMED International. Alejandro is a family physician and medical informatics specialist trained at the Hospital Italiano of Buenos Aires, Argentina. For the last 20 years, he has collaborated with different digital health projects worldwide, contributed to international working groups on standards and interoperability, and consulted on implementing national digital health agendas. As National Director of eHealth in 2019, he was in charge of designing and implementing the National Digital Health Strategy at the National Ministry of Health in Argentina. He was a World Health Organization Digital Health Technical Advisory Group member from 2019 to 2021, and he is now a Senior Implementation Support Specialist at SNOMED International and a former work colleague of mine, which is how we know each other. So with that, I will pass the screen over to Alejandro for his presentation. Thanks, Alejandro.
Thank you, Linda, for the invitation. It's always a pleasure to see you and work with you. Okay, so I know many of you are already familiar with SNOMED in this process, and because in other parts of the courses and your work in the university have already seen SNOMED. So the goal of today's presentation, we agreed with Linda, would be to give you the updates, what's new, what's happening in SNOMED in 2024. So this is like a presentation. We will skip over different things, especially we will go through collaborations, how SNOMED works with other standards. We will go through what are the updates that come from the clinical field. As you know, SNOMED is a dynamic terminology that is updated monthly today. And the clinical reference groups is a source of clinical content for SNOMED CT. We will review some of that. We will also see some demonstrations of SNOMED work in demonstration tools based on best practices for SNOMED and FHIR implementation. And we will show some free open source tooling that we developed to help implementers and to simplify some of the steps of the SNOMED implementation. So I will start going through all of this. It's a variated demonstration of different things. So let's start with LOINC. I know LOINC is important in Canada. Many people use LOINC. And LOINC is a big subject in the SNOMED community. Yes, there's a history of different efforts to try to align and map and coordinate the work of SNOMED and LOINC. But lately, in October 2022, a new cooperation agreement was announced, and this was really successful and a way forward to simplify how these two standards work together. They're both terminology standards. SNOMED has many domains, and LOINC is more dedicated to the observable results domain, mostly laboratory and clinical observations, but it also has panels and questionnaires and things like that. So the organizations got together and decided to work to try to minimize the duplication between LOINC and SNOMED, to say SNOMED will not try to create things that are already in LOINC, and will try to link to LOINC to be able to use that in implementations. So the primary aim of this project was to create a space for LOINC inside the SNOMED that is maintained by LOINC experts. And this is called the LOINC extension. You know how countries create their national extensions? The SNOMED has an international edition, then you have the Canadian edition, and you have the US edition, and the UK edition, and the Australian edition. But the same can be done for domains. In this case, we can have like a LOINC extension. The LOINC extension is the new concept and the models that are required to represent LOINC content. Yes. So there was a preview at the end of 2023 of the first preview of this effort of working together with SNOMED and LOINC. And this preview contains around 24,000 concepts. Yes, these are laboratory LOINC terms. So this was the first stage. And each one of these terms are modeled following the observable entity model in SNOMED-CT, which is one of the kind of concepts in SNOMED-CT. All the LOINC concepts are subclasses of the observable entity concept in SNOMED. They're in that part of the SNOMED hierarchy. And this was the first preview, and it's not complete. So many things were specifically excluded from the preview. And the things that were excluded were things that include divisors like ratios and things like that. Everything that was calculated like an onion gap exactly was also excluded because there's no simple way to do it in the model as we have it today. That's part of the second phase. And also panels. Yes, if you look for something very common like an hemogram, you will see that's still not part of the LOINC extension preview. Yes, because this is like a second phase. Each one of the components of the hemogram may be there, but not the hemogram itself, that is a collection of different determinations. Also, veterinary terms were excluded and other concepts depending on the status. Yes. So there's a browser now. And if you go to loincsnomed.org, you will see some information about the collaboration, the initiative, and you will see a link to the LOINC extension browser. And in this preview, you can see how this concept, for example, substance concentration of glucose in arterial blood at point in time, is actually a LOINC concept transformed into SNOMED-CT. If you see the synonyms, you will see some of them, like the synonym glucose, SSN, PT, PLD, AQN. Yes, this is like the classic LOINC term for this concept. But the effort of integrating LOINC into SNOMED generated the human readable FSN, this substance concentration of glucose in arterial blood at point in time, but also included the LOINC code. Yes, and the LOINC code is included not as a map, but as an alternative identifier. So this is something that was not used a lot in SNOMED before, but it's part of the SNOMED specification. So these concepts have a SNOMED code that you have on the left, the SCTID, and they also have this alternative identifier that is the LOINC code. So these are like codes that belong to both terminologies in that way. And the properties of the LOINC term, the LOINC code, are represented using the observable model. So you can see that we have the property of substance concentration, we have the component glucose, we have the time aspect single point in time, we have the direct site arterial blood specimen, and the scale type quantitative. So everything that is represented in the logic of LOINC is transformed into this representation in SNOMED. And this is ongoing. Yes, hopefully there will be a new preview in October. October is the time of our expos, our world conferences, our global conferences. So the next one is in Seoul at the end of October. So probably by the conference, there will be another preview that maybe extends to other domains of logic and maybe has a few updates of how things are represented. But the goal is to have something by the end of the year or early next year to have a production release of the logic extension. Yes. And this will allow people to, that if you have a system that primarily uses SNOMED, this allows you to use logic without changing your logic. You can use ECL, you can use the findings, the search, the matching, everything the same as if it's SNOMED, but you get the logic codes. Yes. Otherwise, you need to load link into your Fire server in parallel to SNOMED and find a way to connect them. But this is a simplification of that. The next topic is the IPS, the International Patient Summary. That's really important, and it's gathering a lot of traction in many settings. The IPS is a household summary. It tries to be minimal and non-exhaustive. It's especially agnostic. It's condition independent, and it's clinically relevant. It needs to be simple and implementable, and it's designed to be used at any time, in any place, by anyone with multiple beneficiaries. So this is an initiative that originates in an ISO specification, and then extends to implementation sites like the FHIR implementation guide that is like an implementation of the ISO specification. And then you have groups like the GDHP or the EU that are proposing the use of IPS around the world in different environments. Yes. And SNOMED has been working very closely with IPS. They are part of the ISO group that they meet with the ISO and all the other groups to define the properties of the IPS. And there are different ways in which SNOMED supports the IPS. And one of them is to try to provide like a global representation of terms to represent the content of the IPS. So we have the IPS free set that was a list of terms that was maintained by HTIS that SNOMED considered for free as a global good, as an open source global good in Creative Commons. So people can use the free set to use as codes in the IPS. And then the same free set was created as a reference set inside the international edition. So countries that are implementing the IPS can know which concepts are part of the international SNOMED and which concepts are actually part of the free set, and then can be understood everywhere, even when they are not members of SNOMED. So based on that reference set, the next step was to create the IPS terminology. Yes? And the IPS terminology is like a standalone ontology, standalone terminology that is available completely for free. So anyone who lives in a country that is not member of SNOMED International, or people that cannot afford a license as an affiliate to SNOMED, they can get the subset of SNOMED, but they can get it as an ontology. Yes. So when we released the text files, it was really difficult to implement because you need to implement in a database as a pick list or something like that, which is not the best practice implementation. And you were missing the properties of SNOMED. SNOMED, the concepts have relationships, the concepts are arranged in hierarchy. So you can say that asthma is a disorder of the bronchus, that is a disorder of the thorax. Yes. But also the asthma has defined inside of the bronchial structure, and the bronchial structure is a kind of lower respiratory structure tract. But when you have a simple list of asthma and other things, you don't know the relationship between them. So the goal of creating the IPS terminology was to extract the small set, but add to that set the surrounding concepts and the relationships between the surrounding concepts. And this is how the set is expanded to 15K, to 15,000 concepts, yes. And this is what is used as the IPS terminology. And this is available for implementation anywhere in the world. So if you go to the IPS terminology browser, we will share the presentation, and you will have all those links to navigate and to visit. You will see that it looks like SNOMED because you open it, it is very similar to SNOMED CT, but it's a bit shallow because inside physical object, you have only 190 physical objects that were the physical objects prioritized to report content on the IPS. And the same for clinical findings, you have 6,000 clinical findings, and you have 1,600 medications in the pharmaceutical hierarchy. So it's a subset of SNOMED, but still looks exactly like SNOMED, and you can load it into a terminology server and use it like it's a SNOMED. And the goal of this is to simplify the implementation guides. Yeah, so when you write an implementation guide for IPS, you define the terminology binding. This means how the terminology is linked to a field. And let's say you have a field that can be used to record clinical findings, events, or situations. Yes. And if you define the terminology binding using an ECL, then you can do a file expand, which is an operation that expands the values based on a query, for example. And depending on which edition of SNOMED you have, you get different results. But the definition of the rules of the terminology binding are the same because it's the same expression. So for example, if you have the international edition, you expand this rule and you get 124,000 concepts. But if you have the US edition, you have a bit more. And if you have the Canada edition, you have a bit less, but more than international, which are different. And if you don't have a license and you live in a country that doesn't have access to SNOMED yet, you use the IPS terminology and you get 6,000 concepts. Of course, it's less detailed than usual, but these concepts are selected based on frequency. Yes, this is constructed. One of the sources to build this is the NLM core subset, which was created via the reporting of use in different care centers in the US and some in Asia also. So these are much less concepts, but probably the most relevant ones are there. So it's still a very useful resource. And how you can share information between systems, that one system uses the international edition and another system uses the IPS terminology. It seems like it's difficult to share information between them, but it's possible to resolve that using the same ECL. Yes, and there's a new ECL notation that is not yet in production to simplify this. But in general, for example, let's choose a kind of epilepsy in the international edition that is very particular. Yes, so opercular epilepsy, an epilepsy that is related to a specific part of the brain. Not really common to use that. And this is not part of the IPS terminology. So if you share this concept with a country that doesn't have access to the whole international edition and only has access to the terminology, you can do an operation using ECL that gets all the ancestors of opercular terminology, and then gets all the ancestor of the ancestors of the opercular terminology and leaves the leaves. And that you doing this is a bit unintuitive when you see it this way, but you get like the closest concept in the hierarchy above opercular epilepsy that is part of the IPS terminology, International Patient Summary Rhapsody. So using an operation like this, that is a leaf operation that we have like a simpler notation that I didn't copy this time. You get this concept like localization related epilepsy. And this is part of the IPS terminology. And you can see how you can transform a very particular concept to a more general concept. And the same thing applies when you're exchanging concepts between national extensions, because if you choose a concept that was created in Canada and the patient goes to the US, that concept will not be known in the US. But probably both the US and Canada share an ancestor of the concept. So you do a similar operation, not only for the IPS terminology, but also for exchanging content between any SNOMED extension, yes, or a SNOMED version. So this is a resolution to the interoperability challenge. And we also have a demo of that. If you go to this link later, we did this with Linda some years ago. You can navigate the different parts of the IPS. Yes, you can try searching in the old SNOMED or only in the IPS refset and see the difference in expressivity. And there's a tab at the end that allows you to do these conversions between different sets. So it's a way to play around and experience yourself the different versions of SNOMED related to IPS. The next one is the use of SNOMED on FHIR questionnaires. And this was based on the requirements of many countries that are using together SNOMED on FHIR questionnaires. For those that are not familiar with it, maybe I think Linda already worked with this with you, with some of you at least. I know they're using it in projects and things like that. But in general, a FHIR questionnaire it has two resources: a questionnaire resource and a question response resource. And usually you put the terminology bindings, the ones that we were describing for IPS, for example, you put them into the questionnaire resource to say, okay, the value of this question, the response needs to be within this range, it needs to be any clinical finding. And then in the response, you have the actual code selected by the user, in this case, asthma, for example. And the National Library of Medicine created this form builder. Yes, that is a tool that allows you to create complex questionnaires with properties for each question, defining the attributes, the possible values, terminology bindings, and all that. So we worked a lot with different countries that are using this to help them take the best advantage of this. And this tool, this form builder from the National Library of Medicine, implements an additional implementation guide, and that's the structured data capture implementation guide. The structured data capture implementation guide adds a few layers. And one of them is, for example, you can pre-populate your questions based on your patient recorded observations and conditions. So for example, if the patient is a smoker and your question is asking if the patient is a smoker, maybe you can get that question already filled because you have that information already in your system. And this implementation guide provides a way about how you can implement this pre-population of formularies. But also it supports data extraction, yes, and you can mark some of the fields. And here on the right, scroll down and you can see the advanced fields and you say the conditional display. You can define if the field is linked to a terminology server. And you have two selectors here that say add link to pre-populate fire observation and use fire observation extraction. Yes. So using data extraction, if the patient, the doctor or the patient responds to the question, you can extract the fire observation in the question from the question that joins the rest of the clinical record. Yes. One thing that you don't want to do is to duplicate the information in your model. Yes. If you have a field to say what's the family history of the patient, and you ask the same thing inside the questionnaire, you don't want to have a contradiction between what you have in your family history list and what you have in the latest questionnaire. So pre-population data extraction helps you to maintain those things aligned, yes, and reuse the information recorded. This is a screenshot about how SNOMED is used in these questionnaires. For example, you can code a question code. For each question, this is a question from a cancer registry form that says histological tumor type, for example, and you can say either you don't have a question code or you do. If you do, you assign the SNOMED code, the code system for SNOMED, and the display. Yes. And if you have choices, you have the first way to put your choices is use answer options. Yes, and you list all the possible codes that will be shown for the user. This is really useful because the user sees the information there, it's very comfortable, looks nice, everything works fine. You can see the limitation of this, that you're typing codes inside boxes. Yeah, so you can make an error when you're typing the codes and inadvertently paste the wrong code or add a new number or delete a number. And these codes also can be outdated, maybe in the future release concepts getting activated. So the next part of the presentation will try to show you how we can help you with that. Yes, what we designed to help our users on that. And this is showing you the answer options section about the answer. Yes, but if you click next to it, SNOMED answer value set. Yes, you can do an ECL. You can do an actual terminology binding for the form. You can paste an ECL here. You can select which edition are you using in the connected terminology server. You can select the version of the release. And when you do all that, you get like a preview of the value set expansion URL. Yeah. So this is like a validation. So in this case, instead of doing the concepts one by one like this, you have all the concepts in the ECL, and the options are all the concepts that are the output of this query. Yes, not this concept themselves, but the concepts that are the output of this ECL. But again, you realize that you're pasting in the ECL, you're pasting concepts like these that may be outdated or erroneous or something. So when you have a certain scale in your project, this starts to be complicated because you say, okay, questionnaires are great, but if I use too many questionnaires. How do I manage them? Where do I store the questionnaires? How do I version them? How do I maintain the references between the SNOMED concepts I use in the questionnaires and check that they're up to date? Is there any way in which I can reuse sections that are repeated in my questionnaires and things like that? So in order to help with that, we developed a free tool, which is the SNOMED Fire Questionnaire Manager, that is integrated with the NLM Forms Editor, the National Library of Medicine Forms Editor. Yes. So this is a screenshot of the tool. There's a link there. Those you can show it. You can show it to you live. Let me open it so you see the live thing working. This is open source. You can go to GitHub always and see the code and export and implement locally. The trick here is that this tool doesn't store the questionnaires on the tool. It's stored in any file server that you choose. Yes, any public file server that you choose. If you have your own, you can use your own. But if you don't, you can connect to a file server. You use the URL of the file server, R4, and here we ask you for a tag. And a tag is like a label that you will put to all your questionnaires to separate the questionnaire from somewhere else. Yes, this is an open file server from Fire. If I go there, and if I open this, you will see that it's a very large. Oh, let me remove this. Oh, it's here. There are thousands and thousands of things here. Yeah. So if you see questionnaire, let me see where are the questions. There are questionnaire responses, are 86,000 questionnaire responses. And let me search for questionnaire. So I 7,000 questionnaires. So your questionnaires will be lost in this server if you connect and if you don't tag them in any meaningful way. And that's why we ask you for a tag. Anything you save there will be exposed to the public. It's a bit lost between the thousands of questionnaires, but still someone can see what you do. So if it's something private, usually you don't use it for real patient data. You just save the questionnaire definition and some sample responses, but not the real response. So if you connect to a file repository like this, you get a list of your questionnaires. Yes, and these questionnaires have a name, they have a status, they have a version number, they have a type, and then you can do some actions over the questionnaire. Yes. One of the things we did was to work with the National Library to design a way to integrate the tools. So if you click on the edit questionnaire, this is opening the NLM tool automatically. Yes. And once a week, you need to accept the SNOMED license. And so we'll accept it now. And you can see the properties of your questionnaire. And you can go here and click on edit questions, and you can edit the question. And if you go back to the attributes and say reporting form edit, something like that, and you close this, it goes back here, and now it has changed. You can see how the title has changed, and the version is version 12. Yeah, so this is the two sites are connected with each other. And what you can do is you can click here, you can preview your questionnaire, you can see how it's used. For example, tumor. Here we have these options come from the terminology server and things like that. Or you can go back to here and you can click on the validate questionnaire option. Yes, and what it does is this will extract all the mentions of a concept in the questionnaire. Yes, so if the concept is a question code, either if it's an answer code or if it's part of an ECL, and you can see where in the questionnaire the code is used, you will get the concept here. You can click here, and this will try to give you take you to the browser to see information about the code. And then you can run the validation, and you can test against the latest edition of SNOMED. We're still trying to define how you can choose a different edition, because actually the system, for example, this is not completely right because this has like the module ID that is the URI for a particular extension, and that's a code system version and not the code system. So we're still trying to define what's the more pure fire way to choose where you're testing. This is going to the browser and it's testing each one of the concepts to see if they are wrong, they are right, or if they are inactive. And this is an example of a concept that was inactivated. Yeah, so this is this is the concept that now is inactive, and there's a replacement. And this tool helps, if you click here, it will replace the value for you. But also, it will call out concepts that have no name. So you say, okay, this is the name. Are you sure that this is the concept you want in this field? Or when the name is different, for example, let's go down. In this case, we say TX primary tumor cannot be assessed, and the actual name is American Joint Committee on Cancer, PTX. So that difference between the official term and the label you use in your questionnaire is highlighted. In this case, it's fine, but in some cases, they have made a mistake. So the idea is that people can use these tools to better manage their questionnaires. And and we also have these options that are modular routes. The modular routes are questionnaires that combine other questionnaires. So if I click on edit in a modular questionnaire, what I will get is not the NLM editor, but actually a list of the questionnaires that are linked. So this multiple sclerosis root questionnaire combines the identification questionnaire with the clinical multiple sclerosis questionnaire. Yeah, so this, and you can change the order, and you can add another child questionnaire by selecting from the list. So in this case, if you have sections that are the same in many questionnaires, you can actually create questionnaire for the sections and then create modular questionnaires, selecting them and putting them in the right order to get the question. And you can download, if you're using a public server like this and you're afraid that someone may change it or the server may go down, you can download the whole bundle and you can save it locally, and then you can upload again to a different server, something like that. And you keep history. So if you click here, you have all the different versions, and you can view and compare. You can see the name change, for example, and compare the different versions of the questionnaires. So basically, this is like a tool that helps you in this process of matching a large collection of questionnaires, which is something that some NRCs need to do. Yes. And one of the first applications for questionnaire was the Cancer Synoptic Reporting Clinical Reference Group. Yes, they were trying to find a way to make more accessible the structured reporting of cancer. So this project group are different cancers and medical informatics specialists that work together, find like a standard way to use SNOMED with reporting forms. And the main source of structured forms for describing cancer are the College of American Pathologists, that is used a lot around the world and especially in North America. But also there's a new player from many years ago, but newer than CAP, that is International Collaboration on Cancer Reporting. That is an organization that is trying to create an open standard for reporting diseases. Yes, cancer, describing cancer diseases. But they are working together in order to review the SNOMED content and create all the necessary observable entities, body structures, and clinical findings required to represent different types of cancers. And the deliverable of this project will be actually fire questionnaires. Yes, and this is interesting because this is like a maturation over previous efforts. Yes, the normal way to deliver the results of such a group will be a collection of all the concepts that are used in the questionnaire. But then the implementers need to go and create the questionnaires themselves and bind the concept with the right fields and all that. And releasing a questionnaire instead of a ref set is a much simpler approach for implementation. Yes, because you can actually see the codes, you can see the bindings, you have all the information. What they work on is, this is an example of a public free ICCR form for carcinoma of the exocrine pancreas. Yes. You have these forms. These forms have the patient information, and then you have whether the patient had neoadjuvant therapy. You have some conditional, for example, if the option is administered, then you have the option, which one, chemotherapy, radiotherapy, etc. And you can see all the same questions represented as a fire question on the right, yes? And you even have the logic to say, if there is no neoadjuvant therapy, then you don't need to answer the next question. But if you do, the question will be enabled, and things like that. So the questionnaire that the group delivers has the right binding between the question and the answers, the code for the questions, and it has the necessary business logic that describes how the questions are presented to the user. Yes. So this enables some interesting scenarios for national centers, for national cancer registries and things like that. So national cancer institutes can adapt these international questionnaires for the local needs. Probably when you want to use it in your country to describe pancreatic cancer, maybe you have slightly different options, or you have another questions, or some of the questions are relevant for you. So probably you go through a phase of adapting the questionnaire to your needs. But when you do that, you're ready to distribute the questionnaires. And the questionnaire goes straight to clinicians, yes? Modern EHRs have a way to simplify the rendering or the presentation to doctors of 5 questionnaires. There are 5 questionnaire widgets in systems, and there are smart on Fire apps. There are many ways in which modern EHRs can render a questionnaire and present the questionnaire to the doctor. And when the doctor completes the information, the questionnaire is saved locally for local research in the hospital. The information can be exported to the clinical record as observations, as conditions, and things like that. But also, they can send a copy of the responses to the National Cancer Registry. So the National Cancer Registry gets exactly the information they need. Previously, there was the limitation for cancer registries to get the right information was the effort that the clinicians or the EHR need to do, the EHR developers need to do to create the questionnaire from scratch on their tooling without a standard representation. Or other option was that the National Cancer Institute will provide like a web app that the doctor need to go with the new username, with a different password, need to log in and record the cancer there, duplicating the record from the clinical record. So doing it in this way, the doctor works only once, it records the cancer only once in the EHR. The information stays in the EHR, but it's copied to the cancer registry. So this is like a practical way to implement this kind of national registry sharing. And it doesn't need to be cancer. There are many other clinical registries that can benefit from this. And also other groups that met and are working to find the innovative ways to use SNOMED is the allergy and hypersensitivity recording group, for example. So we have an implementation guide. This group met and tried to define what's the best way to record allergies using SNOMED, what concepts were missing. They updated the content, they updated the hierarchy. They were really careful about that SNOMED has best fit for purpose for representing allergy, yes, and they define business logic and everything. And we help them to create an interface demonstrator that is here in this link. And let me show you a second how it works. So in this tool, they define that there are 2 ways of record allergies. Yes, you can record allergies using the problem list. So this is an example problem list. So if you say you want to record diabetes, that is not an allergy, you just use the problem list. But if you record aspirin allergy and you click there and you add the problem, the system can recognize that this is actually an allergy, can put a label, and can extract a substance that the patient is allergic to. And this can be used to detect, for example, to prevent allergies from medical prescriptions, because if you prescribe something that contains this ingredient, you find the interaction there. But the other way to record is to record detailed attributes of the allergy itself. So, for example, this is a file resource that represents allergy intolerance, yes? And this is empty, and you have here like an intelligent form to do that. So if you look for aspirin here and find the same concept, allergy to aspirin, and this is automatically extracting some information. So it detects that allergy to aspirin is a hypersensitivity, that the substance is aspirin, and the type of substance is a medication, yes? And you can say whether this is confirmed, the criticality, you can say that this is high risk, and you can record the manifestations. Each time I select something here, the file resource on the right is updated, and you can see the value. Criticality high, category medication, etc. So let's say the reaction was an edema of the glottis, for example, and we can search that. It takes a bit, maybe the server was sleeping. And you can find the exposure route and the severity of the reaction. And everything is saved into the file resource. Yes, and this is like the result of the CRC, the clinical reference work here. Let's say edema glottis is severe and the exposure route was oral. Yes. So this is not a questionnaire, for example. This is a complex form that has some internal logic. And this is an example of what people can do on their systems in order to implement like a best practice allergy recording. And one of the things you can do is, we are evaluating also, I don't have anything particular here about that, but one of the things we're evaluating is to include these in the Smart on Fire application. Yeah, so if you have an EHR that is compatible with Smart on Fire, but the EHR doesn't have a very robust allergy recording mechanism, you can get this form into your EHR and you can select the information you want, and this form will send the allergy intolerance resource to your EHR, that it will process it and will store it in the right place. Other things that we are doing is to facilitate the use of SNOMED in different settings. We know that we're talking about EHRs that have Smart on Fire that are really high end, but we know that that's not the case around the world. And there are many open source solutions. One of the most well-known ones is OpenMRS. This is one of the most used open source clinical records. Yeah. And BAMNI, the BAMNI coalition is a, let me see something, share sound here, not too much video clip. I was sharing it. Okay. Okay, so I think I shared it right. The BAMNI coalition is an alliance that combines OpenMRS with other tools to create like a suite that is available to use everywhere. Yes, so there are more than 500 sites using it in more than 50 countries. Lots of users, lots of patients. Yes, and the goal was to try to include SNOMED in these kinds of tools as well. Yes, and that's a challenge because that was not done before a lot. So SNOMED International worked with BAMNI to add the best practice. We help design the system, how to do it. We provide open source tools. We developed a light version of our terminology server called Snowstorm Lite that works with very little memory. We created like a simple clinical decision support server, Fire compatible, to connect to the tool. We funded the open source development teams, and the idea was to demonstrate the benefits of SNOMED in these settings with constrained resources. Yes. And these settings, typically, there are no national dictionaries, drug extensions, there are no access to knowledge bases or things like that. So we tried to see what can we do in a setting like that to take the most advantage of robust SNOMED implementation. So I think you will hear the sound. Let me, if you don't, please, Linda, let me know because I changed something.
SNOMED International and the BAMNI Coalition, a group of organizations that use, contribute to, develop, or implement BAMNI's open-source electronic medical record.
You're hearing it, right?
Yeah, we can hear it. Thanks, Alejandro.
That's perfect. Thank you.
Are working together on a SNOMED CT module for integration with the BAMNI EMR to provide structured terminology openly to digitally maturing markets. In this demo, we are simulating a clinical visit. We start by selecting a patient from the list. It's a 65-year-old male with asthma, hypertension, and hypercholesterolemia. He presents to the visit with palpitations and fatigue of recent onset. We will use the history and examination form to record this information by selecting terms from SNOMED CT, powered by Snowstorm Lite, the integrated terminology server. In the consultation panel, we can enter a free text clinical note describing our reasoning. The electrocardiogram results showed atrial fibrillation. We record this primary diagnosis in the next panel, searching in SNOMED CT. The next step is to prescribe the necessary medications, beginning with dabigatran, an oral anticoagulant, to reduce the risk of stroke in patients with this condition. The medications panel uses the terminology server to search SNOMED concepts for the available medicinal products. The clinical decision support system has identified a potential interaction between dabigatran, the medication newly prescribed, and aspirin, which the patient has been taking until now. This interaction was detected using an interactions knowledge base developed for this project, and using the terminology server to compare with the medication ingredients described in the SNOMED concept attributes. We are also prescribing propranolol, a beta blocker, to manage the rhythm and alleviate symptoms. Propranolol triggers a different type of alert, a contraindication in this case due to the patient's chronic asthma. This alert enables us to revise our decision and prescribe atenolol instead, a similar drug that does not have this contraindication. This alert is also an example based on a custom knowledge base, which employs the terminology server to match with content encoded in SNOMED CT. Now we are simulating a data entry error. We have selected 2 tablets of atenolol to be taken twice a day, not realizing that in this system, it amounts to 4 tablets daily. A new alert informs us that we are exceeding the recommended daily dose. This alert is triggered by a knowledge base that uses the ATC-defined daily doses and leverages the detailed ingredient and strength attributes in the SNOMED concepts to calculate the total dose. All the clinical information recorded in the patient's history is readily available for reporting purposes. For instance, we are now going to generate a daily statistical report that includes the ICD-10 code for the primary diagnosis of each visit. This reporting feature utilizes the terminology server to access mappings published in SNOMED CT releases, a result of the collaborative
We lost connection for a bit in the last second.
efforts of SNOMED International with various organizations.
It's okay, it was already finishing. If you can hear me. This tries to
SNOMED
show you
International and
how in a constrained setting you can take advantage of SNOMED by doing some tricks and then making some decisions about how to implement that. So let me change the configuration because it's I will not share sound, I will not optimize. Yes. I see the quality will be better now. Good. I'm sorry. So what we did was we had to map the local list. They have a local list of medications available in their sample that's based in different projects they're working on. We map the local list to SNOMED, yes, and the information is captured using the BAMLI model. And then we need to provide some kind of decision engine based on that. So the use case was to every time the new prescription is added, we use the FIRE engine to detect either drug interactions between drug and drug contraindications, drug disease, and the dose alert decision. And the challenge is where to get the knowledge bases, because in developed countries, you can go to a vendor and pay a fee, an annual fee to get your knowledge base updated every month, and they're really good and it's really easy to implement. But we had to look for public domain databases. It's a way to provide these solutions in these low resources environments. And what we did was to create like local lists. Yes. So for the case of drug condition and drug, we said, okay, in the demo we have only 3 of them, and then when a hospital or institution in these settings want to implement the knowledge base, they can go to a local university, to the medical school, and find the top 10 or top 20 or top 50 interactions that they are relevant for their setting, for example. And that's a way in which you can have your humble decision support setting, but you use all the infrastructure provided by the SNOMED terminology servers. And for the maximum recommended dose, we computed that from the ATC DVDs. And that was an interesting way to do it. You know, the DED is the daily recommended dose in the WHO ATC classification. And so, for example, this is a snapshot of an ATC code, C07ABLC. Yes, so the name is atenolol, and the DDD is 75 milligrams oral and 75 milligrams parenteral. Yes, and if you have your dose forms mapped to the administration routes, yes, you can actually compute the number of milligrams that you're assigning to the patient. And then we decided to put 2 cutoff levels. If you're doing more than twice the recommended dose, you get a warning. And if you're doing more than 4 times the recommended dose, you get a critical alert. So this works like this, yes. So atenolol, milligram, these are the SNOMED codes that are mapped to each one of these. And then you have the information that the patient is taking 4 of these, yes. So you multiply them and just realize that it's taking 200 milligrams a day. And 200 milligrams a day is more than twice and less than 4 times. So you get a warning, yes. And this is like a fun way in which you can see how you can leverage publicly accessible information to introduce some safety measures in low resources settings. Yes, of course, it's not perfect. It's much better to have exact doses for the alert, but these are things that can simplify the adoption in these situations. Yes. And we mentioned that one of the solutions that we had to develop for the project was Snowstorm Lite. You know, Snowstorm is our flagship terminology server. It's an open source tool, completely compatible with Fire, that supports not only SNOMED but other code systems. When you go to the browser and you navigate the browser, you're actually using Snowstorm in the background. It's really, really robust. And we even have a version of Snowstorm that is compatible with post coordination, for example. And it's completely free and accessible. But Snowstorm requires a lot of memory to use it. It requires some training. And it's loading a Snowstorm, it takes like an hour, yes, using an operation to put a new version of SNOMED. So it's really a heavyweight tool, yes. So we developed Snowstorm Lite to replace the Snowstorm in these particular settings. And it has some limitations, but the limitations make it very, very economic and very lightweight, yes. So each Snowstorm Lite has a single edition, yes. And that's normally in any implementation, you only need a single edition. You can do a lookup in the ecosystem, you can expand value sets with what we call ECL Lite, which is a light version of ECL. It doesn't have all the features of ECL, but it has most of them. The ECL group is trying to, the languages group in SNOMED is trying to reach like a definition of what's like a light version of the language, what are the most important operations that should be supported when you do like a light implementation of the query language. But this is an example of that. The Snowstorm Lite also supports the translation, so you can get to access to maps. You can get the ICD-10 code for normal concept and things like that. But the difference, instead of building the index in an hour, it builds the index in 40 seconds. It's really, really different. And instead of requiring 8 or 16 gigabytes of RAM, it gets only 1 gigabyte of RAM. So being so light allows you to put this terminology server maybe in a mobile device, in the same computer that the EHR is running. You can share the resources with other tools. It was really, really useful for that. And then we can give you an update of the existing tools that we have, the RefSet and mapping tools especially. The old one is the RefSet and translation tool. Yes, this is really one of the initial tools that we built in SNOMED. Linda, who knows everything about this, has worked a lot with this tool. It's a very useful tool. It's really, the UI may be a bit antiquated today, but it has all the necessary features, works really well, and it's really open. So anyone can request use like a project in this tool, and we're very, very flexible in giving people opportunity to create RefSets in this tool, yes. It does the basic things. It creates reference sets, simple reference sets, extensional. That means that you select one by one the concepts that you want in your subset, values set, reference set. They are all so I assume you're already familiar with the naming, but subset is like a logical thing. Rep set is the normal representation of the subset, and value set is like the fire representation of the subset. But they're more or less the same thing. And you can create mature ref sets that can lead to a future publication, or you can create local sets, which are small lists that you use in your implementation. You can do assignments and revision. You can translate the ref sets also, because it has a translation module. And it provides some help in updating your ref set to new versions. So if you're using an inactive concept, you can switch your edition to a newer SNOMED edition, detect that one of the concepts is inactive, and replace it. This is old but useful. But we wanted to tell you more about the new ref set tool. Yes, but still it's in internal testing. Apparently, it's doing well. We have a new tool that replaces this one, but for now, it's only available for internal extension projects. So yet the in the implementation team, we are still not using it. It's being used for some countries in the managed services to create some extensions, but still in test and still limited to that. So if you want to create ref sets and you don't have a tool, we can help you with the ref set tool, the old one still. Maybe next year we'll have more news about the new one. And we mentioned that the ref set tool has a bit of translation, but we also have an additional translation tool that is like a professional translation tool designed to translate websites content and different things. It's a classic translation thing not related to SNOMED. But we did an adaptation to be able to use Weblate, an open source version of Weblate, to actually translate SNOMED concepts. So, and this is a tool that is open to all member countries that want to start translation and supports automatic translation and things like that. It's really a useful tool. You have your assignments, you can assign different descriptions, you have some information about the concept, you can click and see more of the concept to do concept-based translation and all that. And I wanted to mention this, probably it's not very useful for implementers, it's more for members and countries. But I want to mention this about translation because we are going to show a tool at the end that combines all these utilities to create an extension. And the next one is mapping. Yes, Snap to SNOMED, also a product of a lot of Linda's work on this. It's a tool that helps you map any terminology to SNOMED setting. Yes, and we have a new version of Snap to SNOMED, and this new version, 2024 version of Snap to SNOMED, it has a better logging process. There were many clicks and steps in the previous one. It includes a new dual author mode that we will describe. It supports the replacement of inactive concepts. It displays the concept definitions. It has a new format for exporting the map. And now you have the possibility of exporting a map as a FHIR concept map. So you can create a map and deploy the map directly to a terminology server and make it available for clinical implementation without the need to release the map as RF2 as a SNOMED extension. So the workflow we had before in Snap to SNOMED that we still have, but this is a simple workflow, is that you add any source code that you want to map, and that is assigned to a mapper, yes, and the mapper creates the map, and then the map is assigned to a reviewer, and when the reviewer approves the map is approved, and otherwise it goes back to the mapper to be assigned or to be reviewed. It's a sequential single author review workflow. It worked really well. But some maps wanted to have some additional quality improvement layers, and they requested for a dual author mode with reconciliation. So in this case, when you have a code, the code is assigned to two mappers, actually. And the two mappers are blind. They don't know what the other mapper is doing. So when the two mappers have completed the concept and they map the concept, then the engine decides whether they agree or they not agree. If they agree, it goes to a reviewer like before. And in some cases, you can skip the reviewer. Yes, if you're confident that, okay, if both authors say the same, then I would do a very light review and just see it on a list or something like that. But if they disagree, they go to a reconciler, and the reconciler will make the final decision, and that would go to the reviewer. Yes? So this is a new way in which you can use MAP, in which you have a stronger quality assurance process because you have the two mappers expressing their opinions and looking for the consistency. And the other one is the replacements of inactive concepts. And you can see this as a theme. We talked about this when we talked about questionnaires. We talked about this when we talked about subsets. And every time you create things in SNOMED, you're always checking in the future to if something has changed, if any of the concepts you use is now inactive or things like that. So when you upgrade your map to a new edition of SNOMED, maybe one of the concepts selected as a target is now inactive. And maybe there's a historical association that will guide you in selecting the replacement of that. So the new version of Snap to SNOMED helps you do that. It helps you detect the errors. It helps you fix the errors, the inactivation by using the historical association. This is how it looks. Now, when you create a map, it's a property of the map. The map can either be a single author mode that is a map like before, or it can be a dual author mode. It's when you decide that when you create the map, yes? And at that moment, you decide which workflow would you use. And this is the new file formats, so you can have an additional comma-separated and table-separated format with additional columns, or you have the Excel extended, or you have the Fire JSON export. So the trick here is that some countries or some hospitals or some implementers want to do all these. They want to create subsets, they want to translate, they want to create maps, and they want all that to go to their Fire server as an SNOMED extension. And that was really difficult, yes, because the files were like independent files. And it was easy to create packages for countries sometimes, because the countries, big countries, can go to a terminology tooling vendor and hire a vendor and contract for using a tool that creates packages for them. And others can hire SNOMED services, they call managed service users. This part of SNOMED International Services. To some of the countries, they pay extra to use a platform that creates SNOMED CT release packages. But if you are a small hospital, usually it's difficult to do that, or if you are a small country that's just starting with SNOMED. So the goal was that if you use these tools that you have today, that we have seen for mapping, translation, and subsets, or maybe use spreadsheets to do your maps, to do your subsets, or to plan the creation of new concepts, there was no way to, from that, get to a release package. And that's what Simplex does, yes? And also Linda chose the name Simplex some years ago. The idea of Simplex is that it should be something that is free and open to everyone. It doesn't require to have a contract to a big platform, something like that. It's scalable, yes, it's very generic. To be scalable, in order to be able to have many people using it, it needs to be very generic. So it's not customized. There's only one way of doing things to make it simple and to prevent failure. The features that are implemented are the most simple and easy to use features. The tool itself will guide you to do everything yourself. So you don't need to have like human guidance or support to do things, including the setup process. And the aim of this is that you don't need to ask for help to the organization, that you're allowed to do everything yourself. And the idea is that you can use our tools, the tools that we just described, to produce high quality standard release that you can then use in an implementation. So Simplex allows you to create subsets, maps, translations, synonyms, and local concepts. Yes, but the local concepts are restricted to very basic primitive concepts. Yes, so you select which is the term of the concept and which is the parent, and that's all you define. For now, at least in this first version of Simplex, we are not allowing users to create attributes and definitions, things that can complicate the release because the classification is not right, because the parent is not right. So this tries to make things very simple. And the goal of Simplex is to assemble all these into an edition. Yes, and also it provides a browser that allows you to see how your edition is going during the maintenance process. And also it validates and creates a formal release of your SNOMED edition. So the idea is that you keep using WebLate, you use the raster translation tool, you use Snap to SNOMED, or you use spreadsheets to do your work. And Simplex will be the bridge to get all that into an RF2 release. Yes. And once you have an RF2 release, you can deliver your content to any clinical system. Any SNOMED compatible clinical system can import an RF2 release. Yes. And this is a bit of the key. This is how the Simplex service looks like. There's no demo after the break. It's I borrowed the slide from our demo in the expo, and there was a demo after the break, but no, we don't plan to do it today. So you have your edition artifacts here. You see how you have a subset, you have a map, you have your translation. And when you click there, what you get is you have the options on the right to operate over that subset. Yes, and the UI tries to guide you over that. It says, okay, you have a subset, you need to choose a file that will import the content that you need, and it's really a guided idea of how to go through that. So let me see if I can show you the live. I'm not, probably not running. Simplex, oh, step Simplex. You know, it's still in beta, so we need to actually go and start the servers to make it run. So it's not possible to do the demo now, but what you see is that. So it's a tool that today we're testing with a few users. We have a few countries, we have a company that are testing it, and we are planning to open the doors for new users of the Simplex service in the October Expo, just like Loin. We're finalizing all the last touches to make it available to more people. We are learning from these pioneer users, everything we need. And the last part that I wanted to show you is the more relaxed part, which is Snowguess. Snowguess is a game. Yes, it's an interactive game. It's a word game that is designed to both. It's educational because it tries to show you how the API works, the Fire API, but also it's a fun way to learn about the content of SNOMED CT. Yes, you need to guess terms. The terms that you use come from the IPS terminology. The attributes of the terms are used as hints. Sometimes you can understand what's the term because you read the hints, you can request hints. And it uses the Fire API to get a random concept, and it's multilingual. And there's a high scores board that is very competitive and people like to work around. The instructions are simple. Yes, you click the keys to the letters to reveal the letters of the word, you guess the term. It's a bit like Hangman. You have life and you lose life when you do a wrong guess, but you earn points when you do a correct guess, and you earn a few lives when you work, and there's a progress there. So let me show you how it works, and hope this is exciting for you. This is the game, yes. So if you click, these are the instructions, and this is the high score. Yes, you can see people from different countries trying to compete to see what's the high score back. And if you click new game, let's do a medium one. Yes, the endless one is hard, but also it has no end. Yes, you can go on. The other ones are capped at 500 points. Yes, if when you go over 500 points, let's go back. Another game, new game, medium, and this may be a bit small. Let me see if I zoom in a bit. So we have a term that has 3 words. It's a disorder, and this has an attribute. This is due to hypertensive disorder. So you know that hypertension is somewhere, so you can start by that. Hypertensive renal disease. If I make a mistake, I lose a life. It's correct, and you continue. And you go away, and you do it as fast as possible to get the highest score, and that will get you to the end. This goes on, you get trophies when you get to the points, and when you reach this point, the game ends, unless you have picked the endless ones. And in this case, for example, it's a procedure side direct knee region structure. And so you know it's something on the knee. And this comes from the attribute. So it's a way of playing around and understanding what's that, yes? And if you do everything wrong, you lose. You lose all your lines. It was excision of ganglion cyst of the knee. And we got a bronze trophy. And we didn't get to write a high score. For that, we need to make at least 100 points, yes? Or use the free one. And you can see this is open source, and you can see how it uses the, oh, sorry, stop sharing. How it uses the Fire API to do the selection and everything. Yes, so let me go back to the presentation. Okay, so that was all. Okay. Thank you very much. But I'm open for questions.